Hello, nurses, and welcome to Cardiac Mimics. That is our presentation for today. I'm so excited to be joining you. My name is Nurse Alice Benjamin, and this is brought to you by nurse.org. And check this out. You will be getting a free CE for tuning in today's presentation and answering a short survey afterwards. So Cardiac Mimics, let's go ahead and get into it. Again, just so you know who I am, I'm Alice Benjamin. I am the Chief Nursing Officer at nurse.org, also a cardiac clinical nurse specialist and a family nurse practitioner with over 24 years experience collectively. My specialties include cardiology, critical care, and emergency medicine. I should say my passions are. I'm also the host of the Ask Nurse Alice podcast brought to you by nurse.org, as well as the founder of Nurse Approved, which is the education company that is sponsoring today's free CE. So, stay tuned, listen to the entire presentation. I promise there's something for everyone in this presentation. Now, while there'll be a lot of you watching, some people who are not in the health profession, some who are pre-nursing, some are nursing students, maybe we have a new grad, maybe you've been a nurse for a couple of years, but you never really worked cardiology, it's not been your thing. Actually, for some people, it's their biggest fear. And then perhaps you're an experienced nurse or an APN, and you're looking for a little bit more information to fine-tune your skills or your knowledge. Got something for everybody who's listening. Definitely want you to know that. Now, I want you to take a look at the gentleman on your screen right here. We've all seen this patient. We have. They're clutching their chest. They're saying, they might even be pointing to where it hurts, but they have this look of agony on their face. Maybe they're diaphoretic, maybe they're pale, maybe they're crying, so many things. But either way, what we do know, or what they've shown us, is that they're experiencing something extremely uncomfortable and it's causing their pain. They don't know what it is, but they're grabbing their chest. So we know that it's somewhere up here, right? At least we suspect it is. And one of our biggest fears, because we know time is tissue, is it a heart attack? I think that's one of the biggest things that we're most concerned about, and rightfully so. If your heart's not working, everything else is eventually going to stop working, okay? We need that good cardiac perfusion. And again, we know that heart disease is the leading cause of death in the United States. Much of heart disease and the things that contribute to it are preventable, or they are manageable with some lifestyle changes, medications, and some other things. And we'll get into that a little bit later. But the most important thing is you as the care provider, you as the nurse, you as the other person face to face with this person who is looking like this. Your patient is experiencing chest pain. What do I do? What do I do? Now, I will say this. Even some of the most seasoned nurses will go blank, freak out, and they're like, what do I do? We've all been there. Now, one of my goals here today is to talk to you about, we're going to talk about we're going to talk about chest pain as it relates to cardiac issues, but we're also going to look at what are some other things that could be causing you to have chest pain, right? What do I do? What are some of the initial things that you need to do as someone who is experiencing chest pain? All right. Okay, so we call this course Cardiac Mimics, and we'll probably do a few of these or do them over again. And thanks for everyone who was so forgiving with the technical difficulty and who is actually watching this now. Thanks so much for hanging in there with us. But what is it? What could mimic cardiac pain? So in this 1 hour course, we'll explore how to know if your patient's having a myocardial infarction, aka MI. What should you ask or assess for, right? You see this person in front of you, but what should you be asking? What should you be looking for? Like, what supports that they're actually indeed having a cardiac event, or could it be something else? Is it a cardiac mimic? We'll look at diagnostic tests. What should be ordered? And what do you do? How do you know it's not an MI? Like, what are the things that we need to do to rule out that there's any cardiac origin or MI related issues happening here? And what else could be causing this chest pain other than an MI? What else could be mimicking that cardiac pain? All right, so here it is. So when your patient's having chest pain, you see this top picture here, like your grad holding his heart, like that's what we think of. That's what they show in the movies. That's what people are anticipating, even if they have anything chest pain, even if they're like healthy as a horse and, don't smoke, like they're an athlete, they're like the most perfect patient you could think of, they're still going to think they're having a heart attack, because that's what we know. Our heart in our chest, that's the thing we talk about. Heart disease is the leading cause of death in the United States. It's one thing that we know is largely preventable, right? Some things we can't, and some things we can manage, but we're concerned. So we think of chest pain, heart attack. We just equate the two. Now, what does our chest pain feel like? That's going to depend. It's going to depend on the person, and that's going to depend on the cause. So some pain, if it's heavy, squeezing or radiating, maybe it's radiating up to the neck, down the arm, you know, that classic heart attack symptoms, it could be a heart problem. Perhaps there is reflux or difficulty swallowing, might be a GI problem. GI problems, and you know, here in our chest as well, and breathing difficulty. Maybe when they take a deep breath, their chest hurts. Could be a broken rib. Could still be a heart condition, or it might be a lung problem. We don't know for sure yet. So I want to remind us of our anatomy and physiology. Now, it's going to be hard to do that in about an hour here, but we're going to do a Cliff Notes version of it. Look at this picture here of the human body. When we think of our chest, we have to recall that the anatomically correct name for it is the thoracic cavity. That's anywhere from your neck to your abdomen. Now, that's a lot of space for us to just automatically jump into the heart. But obviously, we do so for good reasons, right? We know that, again, heart disease leading cause of death in the United States. So, but it could be other things. Look at what else is in our heart. Look what else is in our chest here. It contains organs and tissues that function respiratory-wise, like our lungs, our bronchi, trachea, pleural tissue, things like that. Cardiovascular, obviously our heart, the pericardium, the great vessels, and also lymphatics. Nervous system, we have our vagus nerve that travels down there, sympathetic chain, the phrenic nerve, laryngeal nerves, the immune system, we have our thymus, and digestive. You know, our esophagus is there, and not too far below that, you know, is our stomach. You have the pancreas, you have the gallbladder, you have lots of things in there that could be radiating into the chest, right? Like I said, from your neck to your abdomen. Like if it's at the top of your abdomen level, right, it could really radiate up. It could be a lot of things. We don't know for sure, but we get worried about chest pain. Chest pain. And for whatever reason, we equate chest pain with myocardial infarction. And it's because that's what nursing has and healthcare has like ingrained in our head. Chest pain, MI. And that's what we actually, it's how we educate the public. If you're having any chest pains, go to our emergency room right away. Make sure it's not a heart attack. We've, you know, so our behaviors have actually led us to do that. And that's fine. That's okay. We want to do that. We want to rule out the MI. But there are other things that mimic that chest pain. And we're going to get into that in this presentation. But again, priority, rule out myocardial infarction because time is tissue, right? So what I have on the screen here is the algorithm from the American Heart Association's latest 2020 guidelines about how to handle acute coronary syndromes. It's an algorithm. Now, I'm not going to go in this to detail. For those of you who are ACLS certified, this you know this. And even in school, we go over this. So even if you're not ACLS, you should probably been exposed to this and know, or you're familiar with it. But it's a good cheat sheet to have. And you don't necessarily need to work in a coronary care unit to know what this is. Anyone, anywhere can have chest pain. Remember, chest pain, it just means from your neck to your abdomen. All of the organs and tissues and nerves and stuff in there could be a lot of things that could cause chest pain. But if we believe it is coronary in nature, there's a particular algorithm in which we could and should rule this out. It's based on evidence. Time is tissue. We definitely want to get these things done in a timely fashion so we can recover and reverse any type of ischemia or injury to the heart. So I'm going to leave that there for you all to look at, but we're going to jump into some things. Let's talk about angina, chest pain. Chest pain that is related to the heart here. Okay, angina. Now, there are different types of angina that I want you to be aware of. There's the stable angina, which occurs with effort. And this is kind of the classic one. Like maybe someone's doing, you know, climbing the stairs or they're exerting themselves physically. Then they're like, ooh, I got chest pain, right? We commonly will see some type of T-wave inversion on ECG, but this is alleviated by rest for the most part. Perhaps they might need some nitroglycerin, right? Depending on other comorbidities that may have, like they have atherosclerosis, hypertension, and some other, cholesterol. Like thinking of risk factors, people who might have greater degrees of atherosclerosis might need this. But for the most part, when they're, at rest or doing normal activities that aren't exertional, they probably don't have chest pain. So this is stable chest pain when it is aggravated or provoked by excessive activity. Okay, so I know it sounds really weird because I remember I used to think like, what kind of chest pain is stable? But no, there is such a thing as stable chest pain. But before you just go saying, oh, your chest pain is stable because you saw your patient maybe walking around the unit then having chest pain, don't automatically assume that unless there is proper documentation and there's been workup to really say that your patient has stable chest pain. Now, the other chest pains that we get more concerned about are unstable chest pain, which is like the crescendo, meaning it gets more severe, increased with, and it's more difficult to relieve this type of chest pain. And often this chest pain occurs at rest. Like we can't think of anything that's provoked it. All of a sudden they just start having this chest pain. With this type of unstable chest pain, you may see some ST elevation on your 12 lead. Treatments for this, rest, nitroglycerin, that may help. Sometimes it doesn't completely alleviate it. So the person may need other therapies or treatments, such as drugs that affect the platelets, antiplatelets therapy, or revascularization, like a cardiac catheterization. They might need angioplasty, something of that effect, right? There can be some concerns, but unstable angina we're definitely concerned about. Okay, and then there's a variant that's Prince Metals, which is kind of vasospasms, which I would say when we do, if a patient comes in with chest pain, you're not really sure which one of it that it is, right? Especially if you work in the ER. But when it comes to Prince Metal, you may see some ST elevation during their episodes of pain, and we treat this with calcium channel blockers, something to relax those vessels so they're not actually spasming. This person actually is still responsive to nitroglycerin. And I'll say this about coronary spasms. This is one of those things that's like, we don't really know what causes it, but we know that people who usually have this are people who smoke, who have high blood pressure, who have high levels of cholesterol, or this might be provoked by alcohol withdrawal or emotional stress. So some things to consider if your patient's having some vasospasms. And again, treatment with this would be calcium channel blockers. They're responsive to nitroglycerin. And again, because we said people who have high blood pressure and high cholesterol are prone to it, good blood pressure management, good cholesterol management could help hopefully minimize this type of vasospasm. So there's your angina, right? Stable, unstable, and then you have the variant Prince Metal. Now, let's take it a step further here. You may have heard the term acute coronary syndrome, right? It's an umbrella term. I used to see, as a new nurse, I would see chest pain, rule out ACS. And that would confuse me because I understood chest pain, rule out MI, but I didn't understand chest pain, rule out ACS. So let me clarify that for you. Let me help you with that lesson that took me a minute to learn. But ACS is an umbrella term for situations where blood supply to the heart is suddenly blocked, or I should also say significantly minimized. So if you see this picture here to the right of your screen, you'll see the umbrella. And under the umbrella, you have unstable angina, you have non-ST elevated MI, and you have ST elevation. So acute coronary syndrome, or I'll just say ACS for this presentation, it's an umbrella term, and it's actually a spectrum of things, okay? Unstable angina, definitely not good, but it's definitely not as bad as an ST elevated MI, okay? It gets worse along the spectrum here. And it's really important that stable angina is not a part of the ACS spectrum here, okay? It's important to distinguish if the chest pain is provoked by activity or stress, and is it relieved by rest? If that's the case, your patient probably has stable angina. We know what causes it. We know it's exertional. Usually it's kind of a oxygen demand issue, but hey, we're not too concerned about the person having an MI. Just rest, right? Don't exert yourself so much. Let's better manage your risk factors for MI and be mindful of the activities and exertion that can cause it. So if we know what If we know that you're going to have this chest pain when we provoke with activity, let's not provoke with activity. Okay, simple. Also in this slide, you'll see a kind of an algorithm. Like I said, we get concerned with chest pain at rest, right? That leads us to our unstable chest pain, unstable angina. So if you look to the right of that algorithm, you'll see acute coronary syndrome, and then it further breaks it down to either ST elevation, again, which is your MI, non-ST segment elevation. And then once you do the EKG, let's say you don't see any ST segment elevation, then then the next layer to that, like, what do my cardiac markers say? Is there, maybe they're positive? Okay, that's a STEMI, right? Or maybe their cardiac markers are negative, and then like, unstable angina. So if you were ever wondering or wanted to better understand acute coronary syndrome, that's it. That's it. It's an umbrella term. It's a spectrum from unstable angina and STEMI to STEMI. The further, again, STEMI is way worse than unstable angina, but it's a spectrum. And then once someone has ACS, how do I further delineate what it is? If they have ST elevation, STMI. If they don't have ST elevation, but positive troponins, that's an NSTEMI. Negative troponins, unstable angina. So not that you should go out there being diagnosing stuff unless it's within your scope of practice, but this is helpful information to help you better understand ACS. So again, ACS, ischemia, which can result in myocardial death, right? It's a spectrum. There's definitely an imbalance of myocardial oxygen supply and demand. Causes. There can be a variety of causes for someone to have ACS. Atherosclerosis, which you have here on the picture on your right. So you see that plaque buildup. Now, I will say this. Even if you're the healthiest of the healthiest, eat right, exercise, don't smoke, don't drink, like all of those things, get good sleep, everyone, by the time we're 18, has developed some type of plaque. And the aging process will, just because the longer you live, the more plaque you'll build up, right? Obviously, it's not going to be as accelerated or probably as extensive as someone who has hypertension, diabetes, high cholesterol, and all those type of things. But naturally, just because we age, we live long enough, you're going to get some form of atherosclerosis. Emboli, cardiac emboli. Now, listen, when we think of emboli, I often think of PE, but I'm not thinking of PE in this moment on this slide. I'm thinking of a cardiac embolism. That's actually rare. An embolism that's cardiac in nature is very rare. And if there was to be one, it would really stem from the left side of the heart. But here's some things that in those rare cases where it does happen, infective endocarditis, atrial fibrillation, or prosthetic heart valve thrombosis. Those are things that can cause cardiac emboli. Okay, things that emboli that stems from true cardiac nature, not elsewhere in the body and then moves. Okay, very rare, but it can happen. It can cause this type of unstable angina. Spasms are, coronary spasms are rare. Let's see what else. And blunt trauma. Blunt trauma can be a cause of this, but usually very rare. Could be, when there's any type of trauma to the chest, it can lead to things that go on with the heart, just because your heart's not stationary in your body. It's hanging off of the aortas from like tendons or ligaments. And so it can move. There can be a contusion, there could be arrhythmias, chamber, valve rupture, those type of things. But blunt trauma typically isn't the main cause for acute coronary syndrome, but something to consider, okay? And again, we're going to go into cardiac mimics, but I thought it was really important that let's talk about cardiac MI, acute coronary syndrome. Let's get that down packed. So if I know this and I can rule out certain things, I can feel safe when tests are unremarkable, they're negative, and I've ruled that out, then I can look at what the other cardiac mimics. Just for those who like visuals, here's a slide that shows, myocardial infarction, coronary occlusion, a heart attack. What are some, how does someone's pain usually present, other symptoms that are there, quick little cheat sheet on treatments, dietary restrictions, and other interventions. So I always think I like things like this. Absolutely, especially when we're trying to rule out the most significant cause of what could be causing your chest pain. Want to rule out MI. So here's a perfect slide for you guys to look at it. Now, I will say this, as we talk about symptoms, remember your chest pain, the presentation of chest pain varies depending on the person and the causes. But when it's truly cardiac in nature, we think of crushing chest pain, like elephants on your chest. There's chest tightness, like there's a belt there. And radiates into your neck, into your jaw, down your arm, and things like that. For the most part, that's what we've been taught. But historically, most of the studies when they were studying cardiac symptoms were done in white men. People of color were excluded, and as well as women were excluded. And the reason why, and I'll say this, the reason why many women were also excluded is because of, they didn't want to do any studies or things in women of, especially childbearing age, because they thought that, and now this is sexist, that, they're not, they have periods, they're not going to, they're, as if at the time, women were thought to be inferior. So they thought that men thought that they would negatively influence the quality of their data because women were moody because they had periods, they have children. Also, we don't want to harm the children. So, that's that part I can understand. But still, women were excluded and people of color were excluded, which another reason for that other than racism. But here, I say that to say that there are other people will present differently. If we look at heart attacks and signs in women's and diabetic, people who are diabetic, actually women can present with some more general symptoms. So they might just feel a discomfort. It's not quite that elephant on their chest. And some of the things that women will feel more so than men will be, they'll have a little shortness of breath, some nausea, some vomiting, some back pain, and it'll be like in the upper back, between their shoulder blades and then the jaw. So, and sometimes women will feel anxious, right? Rightfully so, but they'll present differently than the males. So don't exclude someone from having a heart attack just because they're not having that elephant on their chest. That's classic symptoms, okay? And I hate that we call these atypical symptoms. They're not atypical. They're just that people present differently. Women present differently than men for the most part when it comes to heart attack. And as well, people who are diabetic. People with diabetics, because of the damage that high glucose levels can have on the nerves, it can influence their ability for sensation. So patients may have some chest pressure, but it'll be milder, or at least they perceive it to be milder, right? Because of the neuropathy. Neuropathy just doesn't happen in the fingers and the toes, y'all. It can happen in other places. They also might have some shortness of breath or be sweating, have spikes in their glucose levels. And actually, even if you're not diabetic, you'll probably have a spike in your blood sugar level, but probably more so when you're diabetic. And pain might be felt in the upper body, discomfort in both arms, back, neck, jaw, and other parts of the stomach. So it could be a little all over the place. So if someone came in who's diabetic and they presented with some of these things, you might think your first thought may not be heart attack, might be some other things. But I want you to keep that in mind when someone is diabetic, that they may not have the same classic symptoms. And now you understand why, because of the neuropathy that they may experience. But there are other parts to your assessment that you'll also need to know about. And I don't go too deep into this, that assessment, but let me tell you, your physical assessment is going to be key. Physical assessment, asking patient medical history, asking about lifestyle behaviors, all of those things are going to be key information when assessing if someone is at higher risk for having a heart attack. Maybe they are overweight, maybe they are diabetic, maybe they have high cholesterol, maybe they've had a heart attack in the past, maybe there's high blood pressure, high cholesterol, sudden cardiac death, other like arrhythmias or things like that they've had or their families had. So all of those things are going to be important. Physical assessment, patient history, and looking for those risk factors. Do they smoke? A variety of things you'll want to ask in your assessment. But when it comes to the diagnosis of acute coronary syndrome, now notice I didn't say diagnosis of MI. I didn't say diagnosis of MI because I'm looking at that umbrella. So I want you to step back a little bit with me. And remember, an MI, whether STEMI or non-STEMI, is part of the ACS umbrella term. And I don't want us to ignore unstable angina because that's just as important, because if we can catch someone who's starting to experience unstable angina, we may catch them and help intervene before they have that MI. So that's important. So I'm using the term acute coronary syndrome. When someone comes to the ER and they're presenting with any type of chest pain, maybe we suspect ACS. And actually, whenever someone says they have chest pain, we should go through this algorithm, even if we don't believe that they have high risk factors or that they're truly having an MI, because of what I've said with women, with diabetics, people present differently. So to make sure we don't miss anyone, we should go through the algorithm. And I will say this, we don't have enough studies in people of color and in women to really say without a doubt that, how they should present and how they don't present. So when in doubt, check this out, okay? 12-lead EKG. Again, look at their clinical presentation. And this will be interesting because, and we'll get into a future slide about what are the qualities and characteristics of their chest pain. Those are going to be key pieces of information. So I want you to put that in the parking lot for right now. We're going to look at symptoms, like I said, risk factors, past medical history, lifestyle. Yes, I said those things. And a lot of this is happening simultaneously, guys, because we want that 12-lead EKG within the first 10 minutes. We really do. Okay, time is tissue. We're going to run some labs. We're going to look at cardiac enzymes, your serum troponin. Now, there are a slew of labs that have been done, could be done to support whether someone's having an MI, but troponin hands down is the most specific when it comes to cardiac tissue ischemia and ischemia. So used to be, troponin I, which is a contractile protein that's normally found in the serum. It's only released when there's myocardial injury or necrosis. So troponin is contained within the cell. It doesn't come out or leak unless there's injury or inflammation or some type of ischemia or tissue death that's happening, okay? Troponin, for the most part, should be within the cell. 80% of people who come into the ER with acute MI will have elevated troponins within the first 2 to 3 hours of the emergency department arrival. Now, this is why we always ask, when did it start? I don't know if y'all have done this, but I'll give you a little tip here. We ask when the chest pain started because we know that within the 2 to 3 hours, there should be an elevation in troponin. 2 to 3 hours upon arrival. We'll want to do a serial, we may want to do serial troponin. So if it's like, oh my gosh, it just started like 10 minutes ago, and you do a troponin, that troponin may not be elevated. And you can't just say, oh, it's negative, no chest pain, but they're still having symptoms. That's right. So that might be a reason why you need to do a serial troponin. Or if someone is high risk factors, but their chest pain onset was recently, again, we may have tested that troponin too early. So something that's come out about in the last couple of years is a high sensitivity troponin, which is a newer type of testing that detects even the slightest amount of troponin in our lab values. So I've seen this as a critical care transport nurse who goes to multiple facilities. When I say, say, oh, tropes are negative, or okay, that's fine. So you could say the tropes are negative, but I want to know the value because also part of, as a nurse, my responsibility is to look for track and to trend. So a troponin may be negative now, but maybe there's a little bump in it later. Or maybe the first troponin was slightly elevated and now it's like extremely elevated. Like you'll also want to know the trending of your troponin levels. But when you check this out, when you're asking, you'll want to know, is this a troponin I, troponin T, whatever you do at your facility, or is this a high sensitivity troponin? Because when we use just numbers, it can be misleading. So I've gone to places and they're like, oh, the trope was 14. And I'm like, oh my gosh, in most places, right? We're like 14, oh, MI, we're going to cath lab. What's happening? But it was a high sensitivity troponin. Okay, so maybe 14 isn't as remarkable as whether I'm doing a troponin I, where the normal value is less than 0.04. Okay, so please tell me what you are, if you're gonna give me a number, tell me which troponin it is that we're doing, because we can't compare apples to apples. We're not comparing apples to apples with these two types of troponins. Troponin I or high sensitivity troponin. And if your facility is not yet doing high sensitivity troponins, please talk to your manager or director about what's going on, because when we do high sensitivity troponins, we're able to detect myocardial injury a lot sooner. Therefore, we are able to intervene a lot sooner, and time is tissue, as we said before. Now, according to the American Heart, there's some pre-hospital stuff that, you know, like if, I don't know if so many of y'all are EMTs or first responders, but you know, if you encounter someone who's having chest pain, you know, you'll want some IV access, maybe give them some supplemental oxygen if their SpO2 is less than 90. I personally like to use 92 as a rule of thumb, but you know, point is they're statin lower than what should be, especially if don't have any other reasons to, right? If they're otherwise healthy, why would you be statting that low? Give them a little extra oxygen, because remember, myocardial ischemia and myocardial tissue death could be related, one from the blockage, but also ultimately because of lack of oxygen-rich blood to the heart. So let's give them some supplemental oxygen in the interim. Immediately, you might want to give them some aspirin. Now, we usually do give aspirin, right? And we've seen it vary for, oh, we only gave 81. Oh, I gave 162. Oh, I gave 325, right? Really no true hard right or wrong, as long as you give some aspirin, right? Now, but there are some cases where instead of giving aspirin, maybe the patient doesn't tolerate it, or because the physician or a nurse practitioner on board has read some newer studies that show that Plavix can be just as helpful, if not more helpful, in for that first administration. I actually just saw a patient who was in the ER for this, and they actually gave her Plavix versus aspirin. But don't automatically think that, oh my God, they don't know what they're doing. They didn't give any aspirin. Oh, but they gave Plavix. Okay, so how about you know that either can be sufficient, right? And again, unless I want to make sure that for those, be mindful of your scope of practice. So I know there might be some APNs on here who have prescriptive authority, and there's some who are RNs or LVNs, and you're not necessarily deciding what the patient gets, but keep in the back of your mind, these are some of the options for my patients. So in the event you're not seeing what what evidence or standards are saying should be given, you can make a suggestion to the provider. Also, pre-hospital. Nitroglycerin definitely been helpful for active chest pain. You can give sublingually or by a spray. Get them on the cardiac monitor. Some telemetry would be very helpful because we want to see what the heart's doing. Whenever there's ischemia, the heart has a tendency to act a little funny, tendency to have some dysrhythmias. And by all means, it's not uncommon. People will have cardiac ischemia, develop cardiac tissue death, and they will go into some cardiac dysrhythmias that could potentially be lethal, such as VTAC or VFib, and we want to prevent those things. And sometimes when we see things on the monitor, we can get some information. We might see some ST elevation. We might see some depression. We might see some inverted T waves. Yeah, inverted T waves, guys. We're going to talk about that too. And dysrhythmias. Those are things that we'll want to know. That's pre-hospital. Now, when they get in the ED and inpatient care, obviously, we're giving them medications, especially if those medications haven't been given in the field. I've already mentioned those in line one. Morphine. We're giving that for pain and anxiety. There's a sympathetic response to it. Now, I'll say this. Sometimes places aren't giving them morphine because there's some research that shows that narcotics can interfere with antiplatelet therapy. And so if especially if the pain is unrelieved by nitroglycerin, the HA recommends that we start beta blockers, especially in all patients with a STEMI. And there are some things more specific to people with STEMI as far as treatment and interventions. Like, for example, if someone's having an ST elevated MI, we want to get them into a cath a facility with a cath lab that's PCI, percutaneous coronary intervention capability, within 90 minutes, because they may need to go emergent coronary angiography or an intervention. And if it's been more than 120 minutes, if the patient is longer than 120 minutes from a PCI compatible facility, we might need to give them fibrinolysis. So those are some things to consider. Timing is also important, right? So those are things you want to keep in mind and for consideration. That's why we should ask, when did your chest pain start? Medical management, again, with the meds, guys. Okay, this is for this is for acute coronary syndrome, unstable angina, and STEMI, things to consider. There's some drugs affecting platelets that we'll want to give, beta blockers, nitrates. Our ACEs, our antidysrhythmics. These are all medical management for those people that are having chest pain truly in cardiac ischemia related issues, okay? Something to consider. Now, today's presentation really is about cardiac mimics. So I'm going through this just so we can have some baseline information so we can rule out some things before we can think, maybe it's something else. So to kind of wrap up the coronary part of it is, what are some diagnostic tests? Definitely, again, 12-lead ECG, EKG, whatever you want to call it, it's the same thing. Get it done, 12-lead EKG. And I'm going to tell you, placement is important. Placement is important, okay? And especially if you're going to do serial EKGs, leave those stickers on. So when the second person does an EKG, they can go to the exact same sticker placement as the prior EKG, because even the slightest movement of an EKG lead when doing it can distort the image and quality of the 12-lead EKG. Garbage in, you're gonna get garbage out. So leave those stickers on until you no longer need any subsequent 12-lead EKGs, again, within the first 10 minutes. And then also, let's say the patient's having chest pain and you give some nitroglycerin. Well, let me say back up. Patients having chest pain, you'll want a baseline EKG, and then give them the nitroglycerin, and you'll want to do a second EKG after that. Okay, give it a couple minutes to work, right? You can give nitroglycerin every 5 minutes for up to 3 times. You'll want, and let's say they're still having chest pain, you're going to want to do another nitroglycerin. You should be doing 12-lead EKGs between each of those interventions to see if anything's changed. Okay, so if you haven't been doing that, you should be doing that. That is best practice. Some other tests. Now, obviously, this isn't necessarily for the immediate moment in the ER. However, some other things that would be done to rule in, rule out someone's or ACS would be an exercise tolerance test, which is a stress test. Now, there are different types of stress tests, and not everybody's walking on a treadmill when it comes to a stress test. So even though you see exercise tolerance stress tests, not everybody's walking on the treadmill. Sometimes we do that by, we induce the stress with medications like adenosine, a dobutamine there. And when we do those, we continuously monitor EKGs and vital signs during that, looking for, trying to mimic some of the, well, not necessarily mimic, assessing for any type of ischemia that might happen when the heart is stressed. Chest x-ray, want to do a chest x-ray because you want to know what's in the thoracic cavity, like what's going on in there. Is the structure, is everything look okay in there? Besides, as we're going to get to cardiac mimics, there could be other things that are causing this chest pain. And a good chest x-ray is going to let us know. We're going to see if the heart's enlarged. We're going to see if they're, what the lungs are doing. Maybe there's collapsed lungs. Like maybe there's a fracture. Like we're going to see quite a few things on that chest x-ray. Echocardiogram. An echocardiogram is going to tell us about the structure and the function and the blood flow of a heart, right? And listen, when we see an echo, I love y'all, I do. But if another nurse just says, oh, the echo was negative, the EF was 65, that is not what makes an echocardiogram negative or unremarkable, if you will. There is so much more to echo. So when you're looking on your computer screen and you see the value there, 45, 55, 65, whatever number it is, it's usually blue and it's clickable. Click on it because it usually, and I'm saying this for people with EHRs, usually opens up a full report that tells you if you read through it. Now, some people, we jump right away to the impression because we want to know down and dirty what's going on. But if you go back and you look at what the findings are, it'll tell you about the structure and the function of each of the atriums, of the valves, of the wall motions. Maybe there is hypokinesis of the left ventricular wall. Maybe there is akinesis of the ventricular wall. A, absent, hypo, less than. Like that tells us something. Maybe I'm gonna go back to the atriums. Maybe the atriums are dilated. It also sets for, it can also tell you other information about valve movement, if there's regurgitation, if there's stenosis. Like there's so much more to the echocardiogram. So please do not just focus solely on the EF. And by the way, if I may go ahead and say, although this is not a class on heart failure, an EF is a percentage. How much of the blood volume in that left ventricular chamber is getting pumped out with each contraction? It's a percentage, so it's relative. You got a small chamber with 65 versus a larger chamber with 65. The actual volume is going to be different because just because of the size of the chamber. Now I'll say this, we have now HFrEF, HFpEF, heart failure, reduced ejection fraction, heart failure preserved ejection fraction. Look that up if you're not familiar with that. Get up on your heart failure terms. You can still have heart failure and have a normal ejection fraction. And that's usually related to a very stiffened left ventricle. I'm just going to leave it right there. We'll get into heart failure another time. But if you're curious, look that up if you don't follow what that is. But the point is, an echocardiogram can tell you so much more about the heart. And also cardiac angiography. Now, this can be non-invasive, right? We can see like three-dimensional imaging of a heart, and it can also kind of determine if there's blockages in those coronary arteries without us actually having to go invasive when they do with a cardiac catheterization and, you know, looking at it. So that's important to know, guys. And here are some ECG changes. We like nice and normal. And by the way, rule of thumb, just a tip. If when in doubt, look at lead 2, right? Like there's a 12 lead EKG. You're going to need to look at all of them, right? But for the most part, if you want to know, when it comes to cardiac monitoring, lead 2 is like one of the most favorite leads, because lead 2, the way that it looks at how the heart is transcending the electrical impulses, lead 2 gives you the best AV relationship, right? Just by the way it's looking at the heart, and everything in lead 2 should be upright. I like it. Keep lead 2, peace. There's peace in this rhythm. P waves upright, QRS nice upright, T wave nice and upright, nice and normal. Now, when you start to getting to ischemias and different types, you might see some ST depression. So you can see your PR interval there. You see where that's at baseline. Your ST segment is actually below that. So you're gonna have some depression. Other types of ischemias, you know, your ST segment might be normal, right? Might be right along the lines of that PR interval, but you have a T wave inversion. When your T wave flips, so should you, okay? There's something going on, check it out. And then also what we know with ischemia that's transcended through all layers of the heart is that we see ST elevation, right? That's that STEMI, ST elevated MI. So, but take a look at these 3 different ECG changes. Those are the things that could be happening when your patient's having ischemia. And if we don't take care of the ischemia, it will definitely lead to permanent tissue death and more, and lead to an MI. Because remember, unstable angina, NSTEMI, and then you have a STEMI, okay? So keep that in mind. So back to cardiac mimics. How do I know my patient's not having a heart attack? Well, you got to know the things about a heart attack first, which is what we've been going over, how to assess for it, like who's at risk, what are some of the, you know, signs and symptoms, how do they present, what are the tests that I need to do to rule it in and out, right? We said chest x-ray, 12 lead EKG, troponin values, like looking at these type of things. So when you know these things, you'll have an indication of, is this really an MI? Is it, right? So we're talking about the workup. Now, if I can finish off on this 12 lead EKG, for those of you who really want to, one day I will teach a 12 lead EKG class for nurse.org and offer some CEs here, but there's such things as families. And these families are, what it is on your 12 lead EKG, certain leads are clustered. And when there are changes in these leads, it can actually indicate which coronary artery is actually having the problem. So listen, you don't need to have this memorized. Actually, if you had a cheat sheet for this, that's like, I had a cheat sheet for so many years until I memorized this. But you'll see here, like inferior right coronary artery. You look at leads 2, 3, and AVF. When there are changes, ischemia or elevation in those leads, I know, because if I have at least a majority of them, 2 out of the 3, then it's likely that I have my chest pain could be related to something going on in the right coronary artery. Anterior septal wall, V1 and V2. Now it could be either or one of them, or either of them or both of them. But when I have changes here, left anterior descending artery, and this says anterior apical, but anterior septal wall, you might hear. Both of them are one of them. When I see a scheme, ST depression, flip T waves, poor R wave transgression, those type of things, something's going on in my LAD, right? Let's see, anterior lateral wall, V5, V6, and sometimes, and actually, okay, I'll keep it there. Anterior lateral V5 and 6 can be circumflex, but also, and more so the lateral wall can be 1 and AVL. But you can see how anterior lateral, kind of both, lateral. So many times these are actually, they're looking for V5, V6, 1, and AVL. And same here with the anterior septal and anterior apical. Sometimes we're looking at these clusters, but it's the same coronary artery, so you get it. But anyways, if I'm looking for patterns, I will look for these families to see if it's truly coronary in nature, because that's what an MI is, guys. Okay. Either a blockage or significant decrease of oxygen-rich blood to a particular coronary artery in the heart. All right. This is just for informational because it's going to get too much for this presentation, but there are different types of MI, guys. I don't know if you all know this, but there are actually 5 types. There's the type 1, which is the one we most commonly, and the one we've been talking about throughout this presentation, myocardial injury with plaque rupture, that type of thing, you know, STEMI and STEMI. You can put unstable angina. No, you can put unstable angina in there, but there's also type 2 when there's a supply-demand mismatch. So I don't know if you guys have ever seen this, but let's say you've had someone who's septic. What happens when someone's septic? Significant like blood pressure tanks because of all that vasodilatation, the inflammatory response, like fluids leaking out. So it makes us that we become hypotensive. Patient becomes hypotensive. But during that time when they're hypotensive, there isn't a lot of volume there to really perfuse the body, right? Blood pressure is low, MAP is low. We're not perfusing our major organs. One of those major organs is your heart. And because of that, patient will have, you'll see that, oh, patient septic and they had tropes were elevated, so they had MI. That's the kind of MI they had. They didn't have an MI because there was plaque rupture or blockage from that. They had an MI because of a lack of oxygen-rich blood to the coronary arteries during their time of hypoperfusion. Now, you don't go around seeing this charted a lot, not in detail, not most places I've been. I've seen it in places, but those are the 2 most common MIs that you see. But there are other ones. Type 3 is when there's been sudden cardiac death, but they've died before there's been any type of troponin elevation that we could see or detect. And then 4 or 5 are related to the trope went up after a cardiac procedure. So that's the thing, right? You've had a patient go for a cardiac, a cabbage or a PCI, and the tropes are elevated. And we'll say, oh, tropes are elevated, but it's not an MI. It's because they had an intervention. And in the intervention, there was cardiac injury or ischemia or inflammation because, yeah, they were in there mucking around. Makes sense. But those are actually indeed categorized as a type of MI. Okay. Now, what else can cause chest pain? Now that we've gone through all of that cardiac biz, what else can cause chest pain? Well, because not everyone who has chest pain is going to be having a heart attack. Again, let's look at this picture here. Look at all the things that could be happening there. So many things, right? So think about all the organs and tissues that are in your thoracic cavity, and what are other things that can go wrong, that could be bothered, inflamed, hurt, fractured, broken, infected, that can cause chest pain. Sounds like a lot, but but let's break this down. Chest pain. Did we say cardiac pain or we said chest pain? Remember, chest pain, just whatever's in your thoracic cavity from your neck to right above your abdomen. Here's some other causes for chest pain for you to consider. Now, we'd be here all day if I went into all of the diagnostics for each of them. So I'm just going to go kind of a down and dirty of some of the other common ones and some things that you can look out for in your assessment and diagnostic tests to consider. So here you can see a list: myocarditis, aneurysms, dissection, pericarditis, valvular disease, hypertrophic cardiomyopathy, heart failure, cardiac tamponade, like so many things that aren't necessarily truly heart attack in nature. Now, this is going to sound weird, so let's break it down. Type 1 heart attacks are from a rupture of plaque, which causes an occlusion in your coronary arteries, which then leads to ischemia, and it leads to tissue death and MI. Boom, right? That is a type 1 MI. And those are the things that we were trying to rule out initially, because those are the type of procedures where I can go to the cath lab and try to fix something. I can go in there and do put a balloon or a stent, or start them on some type of anticoagulations or some clot busters to kind of open that clot up, right? Here are things that cause chest pain that are still cardiac in nature, but not necessarily those interventions that we do for that MI type 1 aren't necessarily going to work for this, but they're still cardiac in nature, right? So here are some things for you as a nurse to consider. Again, physical assessment is going to be king here. You gotta do a good assessment, guys. It's a good assessment. So heart sounds. Are you listening to your heart sounds? Right. And I don't mean just place a stethoscope over your chest, but are you listening over each of the valve areas, right? Aortic, pulmonic, tricuspid, and mitral valves. Are you listening to over all of those, right? We want to listen to those. That's going to help. You're going to see, listen, are there any murmurs? Murmurs can be indicative of stenosis or it can be indicative of regurgitation. Let me take it a step further and give you some tips. When you're listening to the heart, put your stethoscope on. Got mine over here, I can't reach it, but put your stethoscope on and listen over those heart valves. Now, let's say you hear something that sounds like a helicopter. Literally, instead of lub-dub, it's like, it's that legit sounds like a helicopter, like a baby. And you know there's no baby up in that chest, right? Not up there, at least. So if you take your fingers and you palpate the radial pulse, at the onset of that helicopter sound, is that onset happening on systole or diastole? Because that can tell you if you are having a systolic or diastolic murmur. Now I'm gonna leave it there because it can get really confusing. And that's not for this presentation, but maybe for an advanced cardiac assessment. But you can tell if your patients have, it's part of your assessment tools, like a real sharp tool. I had a cardiologist teach me this because I was just like, boom, patient has a murmur, or, you know, an aortic murmur or whatever I said. He's like, okay, is it systolic or diastolic? Is it a result of regurgitation or stenosis? And I was like, I thought I'd arrived, but there's actually, you can take your assessment skills and fine tune it. Now that's not a diagnostic absolute test because it's not completely objective, right? It's a part of your assessment. It's a sign, but it can fine tune your assessment so that you can actually go down the algorithm for workup a lot sooner. I can listen to someone's with my stethoscope, palpating the radial pulse. They have mitral regurgitation, and it's or it's over the mitral valve, and the sound is related to mitral regurgitation based on where I hear the onset of the murmur in the cardiac cycle. Is it systole or diastole? So I'm gonna leave that there, parking lot. Also, are there any gallops? Are there any rubs? Are you hearing different extra heart sounds? So we know lub-dub, S1, S2. Is there an S3? Is there S4? Those type of things. When you think of S3, I'm hearing S3s. Oh my gosh, maybe they're having some heart failure. Maybe the heart sound very distant and muffled. Oh my gosh, maybe they're having cardiac tamponade. So like, I promise you, your assessment is key in this. Also, you want to look at dysrhythmias, the EKG, right? Make sure they're on monitor, make sure they're on the proper leads. Usually people are watching in 2 leads, a limb lead and a V lead. I like lead 2 and then V1 or V5. And so we're looking for dysrhythmias. Is it a normal pattern, or are they having, dysrhythmias, like maybe they're having runs of VTAC? Or let me say this, maybe they're having occasional PVC. Okay. No, we're usually not too worried about occasional PVC, but if they start having triplets or it's more often, oh my gosh, I better check my potassium levels because could be the potassium levels too low and heart's becoming irritable. Maybe the patient's going into SVT. So the heart's beating so fast, it's causing a demand ischemia type of chest pain. Maybe the patient's in AFib with RVR. They're in AFib, which already decreases cardiac output by 30%, but now they're in rapid ventricular response, which further decreases the oxygen supply for the heart. So things to consider. Your arrhythmias are also helpful in assessing, why does my patient have chest pain? Is there pain on inspiration? If someone's having pain on inspiration, what happens on inspiration? It increases intrathoracic pressure. Usually when someone's pain worsens on intrathoracic pressure, that's usually an indication of inflammation. Okay, it could be cardiac tamponade. Is there JVD? Looking for JVD, positive jugular venous distension. That could be a sign that if they are, right, let's say they're big, they're fluid overloaded. Could they be having heart failure? Like, these are things that you want to do in part of your assessment. Now, labs and diagnostics. Obviously, we're always going to do CBC, CMP, like those are like standards, but with cardiac, we want to look for inflammatory markers like your CRP, C-reactive protein. C-reactive protein is like, goes under the radar all the time. Now, it's not specific for cardiac. However, whenever there's An elevated C-reactive protein, it indicates that there's inflammation. And usually when there's when that levels increase and we know it's a sign of inflammation, we get concerned about atherosclerosis, which could put them at risk for the type 1 MI, but it also lets us know like, hey, there's some small inflammation going on here. What's going on? Maybe there's something else that's contributing to this chest pain. BNP, beta natriuretic peptide. That is a real important lab value that distinguishes when someone's short of breath. It can distinguish between if it's pneumonia or if it's heart failure type of thing, right? That's important. We'll also do some imaging like X-ray, cardiac CT, heart MRI, echocardiograms, those things that we want to look for as far as structure and function of the heart. And also in some of those tests, you can actually get a 3D image of if there's blockage in the heart without actually having to be invasive. Again, like I said, we're going to look for certain EKG patterns and changes. Something I didn't mention earlier, but let's say your patient's having ST elevation and we think, oh my gosh, it's cardiac MI. Remember those families that I talked about? Usually those families are like, it impacts one coronary artery, maybe two, right? But generally not all of your leads are going to be ST elevated. And when it is, it could be a sign that the patient's having pericarditis. Other patterns, if there's a left bundle branch block, could be a sign that the patient has hypertrophy, right? So now some of these are like more advanced skills, but I'm sharing these so you'll know, you can play this back and listen to it. And then also cardiac catheterization. Now we do cardiac catheterization because we want to go in and we want, obviously, let me say this, there's a right heart cath and there's a left heart cath. So not all cardiac catheterizations are the same. They're not going to, depends on what you're going in for. There's a right heart cath that they'll do, and they'll go in looking really more for like pressures and things like that. Left heart cath, pressures and function of the heart. Left heart cath actually goes in, and that's how they go and they look for coronary artery, status of your coronary arteries. So sometimes they do both, sometimes they do one. But whenever someone's going for a cardiac catheterization, you'll want to know, are they doing a right heart cath? Are they doing a left heart cath? Is it going to be both? Is this something that's diagnostic where we're just going in and looking? Or is this also, I said diagnostic or interventional, where they're going to go in and, they're going to possibility for angioplasty, stent, ballooning, da, 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 da. So understand when your patient's going for a cardiac cath, be that nurse who really understands what kind they did and what did they do, okay? That's important. But these are things, other causes that, other things that can cause chest pain. And here are some things to work up. Some of these, again, some of this workup is going to help you rule out the standard MI, right? But then it's also going to help support some of these other things that are going on, like my BNP is elevated. That chest pain is from more than likely from heart failure. Let's do a chest X-ray. Let's confirm. Let's see what the heart, let's see what what's going on with the, what did I say? I said, let's do a chest X-ray. Let's see if there's, any fluid overload into the lungs and other things. So you do things to kind of support the diagnosis that you're looking for. But I think I've touched on most of those. Something else that we see, pulmonary causes of chest pain. Listen, there's a whole bunch. This is just a few. Pulmonary hypertension, pleurisy, pneumonia, pulmonary embolism, tuberculosis, asthma, pneumothorax, COPD. Like, remember, chest pain, anywhere in the chest. All these things could be happening. Physical assessment. What's my SpO2? Maybe they're desatting as they're happening. Now, for the most part, when someone's having an MI, they don't all necessarily desat, okay? So that's just something for consideration. But if you have someone who's having chest pain, again, physical assessment is going to be key. What's their clinical presentation? What's their history? Risk factors, lifestyle, do they smoke? Like all of those things, you got to know those things. So that's going to be important. But also, let's take a closer look at SpO2. Let's look at their breathing pattern and their rate. Maybe are they hyperventilating? Maybe they're breathing at a rate of 32. That generally isn't a classic symptom of an MI, right? When we're thinking about chest pain. Pleuritic pain. Maybe they have that pain upon inspiration. Again, it could be a sign that there's some inflammation going on. Maybe their chest pain worsens with movement. That could be a sign that maybe they have I'm gonna go with that. A rib fracture, right? Could be that they have an pneumothorax, also with pleuritic breathing and worsening of pain or movement. And then pain associated with a cough. Maybe sometimes people cough so hard they have chest pain. Like these are things you're gonna all consider as you're collecting data, as you're doing your physical assessment, and then also as you are, you're gonna be talking to them, asking questions. Now, I'll say this, one thing I didn't list here is like heart sounds again. So remember I said, are you listing over all of the valves? Sometimes if you, let's say you get to the pulmonic valve and you hear some regurgitation. Is it stenosis? Is it, excuse me, you hear a murmur. Is it stenosis? Is it regurgitation? Could be a sign that there may be some right-sided heart failure, or maybe that's related to, again, pulmonary hypertension, things like that. But listening to that could give you an indicator like, pulmonary valve's acting kind of weird. There might be something going on there. Pulmonary could be, are the pressures in the lung so high that it's backflowing to the heart? Okay, something else, diagnostic tests to consider. Imaging, definitely chest x-ray, CT of the chest. We want to know what's going on in the chest. What does it look like? Any concerns? Are there tumors? Does everything place where it's supposed to place? Is there an enlargement? Is there, what else is going on there? Do VQ scan to see if there's any perfusion oxygen mismatch. That can help you ascertain if there's a pulmonary embolism, as well as, I know people are going to say you can do a D-dimer, check for D-dimers for PE. But labs, ABGs, we'll look at those. Maybe there's an infection. Maybe they have tuberculosis. Have you sent a sputum? Are they having AFBs? What else? EKG, another EKG change that might be more specific to pulmonary. It could be a right bundle branch block. You might see that. Now I'll say this, when you look at, if you're looking at a lead 2, you can't say, oh, that's a right or left bundle branch block. There's actually a more distinct way to determine, looking at V1 and V6 of a 12-lead EKG to determine if someone's having a right or left bundle branch block. That's not for this presentation, but just for FYI. So we know that a bundle branch block is a widened QRS complex of greater than 0.12. But if you do a 12-lead and you get a chance to look at it, they might have a right bundle branch block. It might be indicative of COPD, pulmonary hypertension, or pulmonary embolism. Pulmonary function test. Maybe someone's COPD has gotten so bad that it's actually causing them chest pain. Something else that you can do is also echocardiogram. Again, it's going to tell us the structure and function of the heart. They'll let us know maybe the person has elevated PA pressures or structural heart changes that could be causing that chest pain, but it's stemming because there's an issue in the lungs. There's a problem in the lungs and it's backflowing to the heart, so it's causing chest pain. Now, the chest pain really is stemming from lungs, but it could also be felt in the heart, but the underlying issue is in the lungs. So some things to consider. Some GI-related causes for chest pain, things to consider: pancreatitis, esophageal spasms, esophageal hypersensitivity, esophageal rupture, peptic ulcers, GERD, hiatal hernia. Again, physical assessment is key, right? The presentations, risk factors, lifestyle, things like that. Now, the pain for GI can be a little bit different, like jabbing pains. There could be a general tightness in their chest area. They might have some belching or indigestion. Might get worse with excess gas. Sometimes they have a loss of appetite also, or they're bloated. Maybe the pain shifts to different parts of the abdomen, like it's moving. And sometimes the chest pain is situational, right? Maybe it improves with position changes or with meals or antacids. So for example, if someone's having GERD, maybe after eating, if they lay flat, they have the chest pain, but if they sit up, chest pain goes away. Or if someone is having like a peptic ulcer, maybe their chest pain gets better after eating when there's food in their tummy. Also along the lines of GERD, maybe antacids help alleviate the chest pain, right? So those are things to consider. They're not completely diagnostic, but they are assessment tools that'll help make you the better nurse, so we can really, get down to what's happening with my patient. Also, some people will say, oh my gosh, I had this sudden, this sudden electrical shock right here, but it went away. Usually those things are nerve related, okay? Not too concerning for an MI. They're usually some type of nerve related type of pain. There could be some neuropathy going on, some other things going on, but it's still worth evaluating. But right now it's not too concerning for an MI. Some other diagnostic tests to consider: labs. Always want to do labs, CBC, BMP, but maybe WBCs are elevated. Maybe there's an infection or something going on. Amylase, lipase, we want to rule in, rule out pancreatitis. Something else I didn't necessarily mention here, but let's not underestimate the gallbladder. The gallbladder, so looking at like your bilirubin levels and all those type of things are important, and LFTs that can give some information. Imaging, obviously, because we don't have that type of vision by just looking at someone. We can look at the abdomen and see what it looks like. I mean, that's part of your assessment, right? Is it bloated? Is it firm? Are they guarded? That's all helpful information, because perhaps that abdominal pain is radiating up into the chest. But you'll want to do ultrasounds, CTs, understand what's going on there. Endoscopy. Sometimes, especially if they're having esophageal issues, you need to do an endoscopy to get down there and see what's going on, because we're not going to be able to see that with the naked eye. Barium swallow, that'll also tell us information. And then esophageal manometry, that will help with, like, is your patient having esophageal spasms? Stuff that I don't know, that I can't see, but that because of its location and because of its proximity to the heart could be leading, helping, could be causing the patient to have chest pain. Because guys, until you ruled in or ruled out something, you can't say for a fact what it is. And in fact, that's what leads to a lot of health disparities and unequitable treatment of people, especially people of color and women. They're like, oh, I'm having chest pain, and we don't do the workup because we just write it off for something else. We need to do the proper diagnostic test. And for everyone that has chest pain, rule out the MI, right? And if they have risk factors, maybe they have acute coronary syndrome. Whatever the case would be, let's look at ACS first. And if those are all ruled out, here are some other causes for chest pain that might be GI related. Some other causes of chest pain: musculoskeletal. So costochondritis, muscle strain, injured ribs, fibromyalgia, rheumatic diseases, nerve entrapment or root pain, herpes zosters. And there's also some psychological things: anxiety and panic attacks. So many things. Assessment is key. And when it's musculoskeletal, usually that pain is reproducible. So when the pain is reproducible with certain maneuvers, it's very unlikely to be cardiac MI type 1 in nature. Okay. And actually type 2, not type 2 in nature too either, because remember, type 2 is demand supply, myocardial oxygen demand supply issue. But the pain worsens when they move their chest, they twist their torso. So it could be a strained muscle, something like that. Pain usually increases when they breathe in deeply or sneeze or cough. Again, those could be because there's signs of inflammation or things like that. When someone says they have chest pain and it's more right-sided, not saying that exclusively eliminates chest pain because your heart's on the left, but if I've ruled out troponin is negative, EKG looks negative, they don't have any risk factors, they're having right-sided chest pain, I might be more inclined to think of something else. Chest pain, they also might be having some numbness and tingling, or shooting pains that extends to your back or neck. Now, back pain could be something, MI in nature for a woman, and in your neck, could be a sign of chest pain, right? Or a true myocardial infarction, but not necessarily shooting or anything that's reproducible. And then are there any other cluster symptoms? So like, for example, with fibromyalgia, someone might have some chest pain, but fibromyalgia is a widespread musculoskeletal pain that someone experiences, and it's also accompanied with fatigue, sleep, memory, or mood issues. So while we're asking patients about their presenting in the moment, it's good to ask, when did this start? Any other symptoms, anything else bothering you, so you can paint this clinical picture. So if someone comes in and they're like, oh, I have this chest pain, I'm here for chest pain, but then they said, I've had this chest pain for 4 years, and they described that they had problems with fatigue and sleep or depression or something like that. After someone has to do it. I don't know if you're going to do it in your ER, but someone has to do it at some point. They need to work out and prove that it's not myocardial infarction. And once they've done that, we can work up some other things. But this might be someone who has chronic pain and it's not related to the heart at all. Anxiety, panic attack, these are usually situational, like provoked by certain things. Like some people get anxiety when they're in public settings, or maybe someone just died, right? It's situational. they will have this pain. It's usually sharp, doesn't radiate. And most of the times they can pinpoint. So have you ever heard someone, a doctor say, well, point to me where you're having the pain. And they might say, right here, right there. But someone who's having a heart attack will just say, ooh, like right here. And they'll point to like some of those classic places. And again, more concerned with situational chest pain, especially if it's psychological in nature. So diagnostic tests consider after you've ruled out all those all the MI stuff, right? Troponins, EKG, chest x-ray, all those things. Someone's got to do it. I don't care if your patient is 24 years old, young and healthy, and they don't necessarily have the typical guys risk factors for an MI, right? What are they? We know someone hypertension, someone with diabetes, someone who's overweight, someone high cholesterol, someone who smokes, sedentary, male, those type of things. Even if they don't have those, you got to still check it out, because what I didn't mention earlier is that I've had 24-year-olds come in with an MI, but it was usually drug, it has been, sometimes it's been anxiety and panic attacks, but there are other times where they were truly having an MI. And then there was some situation where it was drug induced. So you don't know, I hate to say this, but stereotyping is, it's like profiling. We should not be doing it, because it actually has some racial discrimination undertones in it. However, sometimes we do it in healthcare because we're looking to expedite getting to a clinical diagnosis. So we think it's a good thing, so we do it, when it's still really not a really cool thing to do. Because when someone comes in and they present, we should be taking their concerns seriously and assessing what it is they say. And then, yes, if you believe that someone has increased risk factors for something, we want to kind of expedite that pathway. But I say that to say, even when someone doesn't meet the criteria for certain risk, for having risk factors or certain things, don't discount them, still work things up. So, okay, back to diagnostic tests. So if we think it's musculoskeletal or anxiety related or psychological related, some other things we can do: a nerve conduction test, electromyography, musculoskeletal ultrasounds, x-rays, MRIs, a referral for a psych evaluation. Maybe someone needs therapy. Like, there's so many other things that we need to work up and do. We don't just write them off like, well, it's not an MI, bye. We don't do that. We don't do that. Now, understand the ER. Sometimes providers are like, oh, it's not an MI, it's not this, not follow up with the primary care provider. Okay. A primary care provider, a nurse, someone's going to need to educate the patient that even though this is not an MI, your chest pain is very real. And it's important that we get to the underlying cause of it so we can treat you. And so you don't have to keep coming into the emergency room every single time. And the last thing we want someone to experience is chest pain fatigue. And they're like, oh, this happens all the time. This is not an MI. And it ends up being an MI. So you as the healthcare professional, you as the nurse, have so much power in your assessment, in the helping the prescribing or ordering provider to rule in or rule out something by offering your suggestions and contributing your assessments, and actually interpreting the data as well, because sometimes providers miss some things. And you as the nurse, if you see that patient's C-reactive protein is elevated, I know that he didn't, there was no ST changes. I know that there weren't any, the troponins were negative, but just because someone didn't have an MI doesn't mean they don't have unstable angina. Or maybe, right, patients came in for chest pain and they did the echocardiogram and the EF is 65, but when you took a closer look at the results, you saw that they had, a stiff ventricle, hypokinesis, like wall and structure, abnormal movement and structure. All of the providers should have seen that. If you see it, you can let the provider know, like, hey, I saw this, I know the EF was normal, but the patient has this, this, and that. How would you like to treat the patient? Because at the end of the day, we want to get to the patient's underlying cause for chest pain and resolve it. We don't want to mask it with pain medications. We want them to be comfortable, so we may give them pain medications, but we got to get to the underlying cause and make sure that we are containing whatever it is that's going on and trying to reverse it so they no longer feel the pain or discomfort, and so that that problem doesn't become more serious. So it's important to understand what is truly cardiac acute coronary syndrome in nature, and also what are other causes for your patient to have chest pain. Chest pain is very real. And it's very important that we as providers understand that there are a variety of reasons that chest pain can be caused. Don't just brush someone off without having done the proper assessment, diagnostics, and treatments. That's not cool. That's not what we do. We're in the business of helping people to get better. So, gosh, I know that was a lot of information in a short period of time. I wish I would have had more time to go into more detail about all of the diagnostics and tests for each and every single disease process. Not in this presentation, perhaps in the future, we will be able to do that. But if you have any questions, and again, thanks for those who stuck in there with me when I was having technical issues, and thanks for watching this video. But if you have any other questions, please leave those questions down below. And also, I am human. Sometimes I talk really fast. I didn't have a live audience to autocorrect me. But if I sense anything that you felt like, oh, Nurse Alice, I think it's this, not that, let me know that too, because I say things really fast sometimes and I'm thinking it correctly. Sometimes it doesn't come out right, but I'm just really excited about this topic because I think cardiac mimics is such an under-discussed topic and it's really important. And I think it's important that we use that terminology with some of our patients so they understand that, you know, yes, your chest pain is very real, but no, not every chest pain is related to heart, cardiac, MI in nature, and these are some other things that can cause it. So we can help people get, you know, closer to what it is that's bothering them and get a treatment plan for that. So let's see. On to my next slide. Okay, it's thinking. In the interim, thanks so much for tuning in. Again, I'm Alice Benjamin, Chief Nursing Officer at nurse.org, 24 years of experience, cardiology, critical care, emergency room, that's my jam. I am here to educate and advocate for nurses as well as the general public, because my goal is that I want to talk to people before they become my patients. And I hope that with the information that I've shared, you're able to do just that with your patients as well. Make sure to check out nurse.org. Thanks so much to nurse.org for hosting the events. Tons of great information on their website. Also, thanks to nurse.org for hosting the Ask Nurse Alice podcast, where we present every weekly. There's a new episode. Check that out. And then if you have any questions or comments for me, maybe I can help answer these. Again, leave it down in the comments. I'll get back to you, or you can email me directly at nursealice@nurse.org. I'd be happy, totally happy to talk to you about more about whatever you're asking about, and then also invite you to future events. Guys, we got more presentations like this happening. We have other events for nurses that are coming. We're going to be coming to a city near you, doing live events, more CEs, and getting you the things that you guys want. So you can be, you know, feel better about being nurses, know more, feel better about your jobs, handle certain issues. We're going to talk about a whole bunch of stuff. But again, I'm Nurse Alice. Thank you so much for tuning in. And please make sure to sign up for your CE. If you haven't gotten an email, for those who registered for the class, you will get an email for your presentation. Oh, let's see. I went. Let's go back. There we go. Thank you so much for joining us today. So for those of you who registered for the class, you will definitely get an email about your CE. For those of you who didn't register for the class, I got to figure that out. What does that look like and how can we get a CE to you? Because we weren't prepared for that. We just wanted to share this good information. But stay tuned. More CEs coming. Thanks to nurse.org. And thanks so much for joining us today. Bye now.